Hey everybody, this is Maggie and we're on another episode of SRH Access Facebook Live. Today I'm here with Director of Orthotics, Don Virostek. We're so excited to have you.
Well, it's great to be here.
Yeah, welcome aboard to this weekly adventure we're going on. So today we're actually in one of our orthotics clinics. So why don't you tell us about what happens in here?
Yeah, basically what we do is we see most of the kids that are referred down to the orthotics department that are needing braces. Most of the braces that we make support one portion of the body to give them support when they're walking. We do a lot of braces for clubfoot babies. We see a lot of kids with cerebral palsy, spina bifida, and we treat a lot of scoliosis as well.
Wow, so everything is done in-house.
Yeah, well, probably 90% of what we do is custom made. We take a mold or a scan of that patient, of the part that we need to make the brace for, and then we go ahead and fabricate the brace at that point.
Look who just joined us.
Hi,
Chief
how
of
are you?
Staff.
Sorry, I got caught up. How are you? Everything okay?
Yeah.
Good. Hi, everybody.
We just got started.
Okay.
We're kind of
Please have a seat.
he was just explaining the orthotics lab and
Yeah.
what we do here and
Right.
just kind of the different steps.
Yeah,
so,
don't let me interrupt.
Yeah, so we can just keep going with that. So you were talking about the different kind of conditions that you treat and what and what bracing is used for.
Yeah, absolutely. We are treating a lot of kids with cerebral palsy and spina bifida, and most of the time we're using braces for their lower extremities, and we're really trying to offer those extremities support to allow them to ambulate. And we're using braces that are below the knee. Most of the braces we use are plastic devices. When people think of bracing, they think of sort of Forrest Gump and using metal braces, and mostly everything we do is plastic, and it's all custom made to a mold of their leg or arm or back, whatever we're doing.
So maybe let's start focusing on scoliosis bracing. I know that's kind of what we're talking about today. So what is it that this brace does for a patient?
Yeah, the ultimate goal with treating scoliosis with a brace is to really prevent that curve from progressing. The kids are usually braced with curves anywhere from 20 degrees up to 45 or 50 degrees. And our goal with that brace is really to try to straighten the curve out while we're using the brace and holding it straighter as they grow. As soon as the child is done growing, then we go ahead and get rid of the brace at that point. Usually our most common form of bracing that we do is for the adolescent kids with scoliosis. So that's happening anywhere from 10 years up to 13 or 14 years of age. So depending on at what age they're diagnosed with the scoliosis depends on how much or how long they're going to have to use that brace.
Right. So Dr. Sucato, when you're looking clinically for kids who need to be braced, what are you looking for?
So much like what Don said, we're looking at the child's curve magnitude. So as we've talked about before in this forum, a Cobb angle is the measurement of the amount of degrees of the curve. So that's one factor. The age of the child and whether they still have a lot of growth left, because scoliosis gets worse in two main ways. One is if you're still growing, and the second is if the curve is so big, above 50 degrees, the curve still wants to get bigger, even if they're done growing in their spine. So the bracing indications are for curves, as Don said, between 20 and sort of 45 degrees, in which the children are still growing. And so we measure x-rays every time the child comes in. We look at what that curve magnitude is, and then we try to assess how much growth they have left. So we look at age. In girls, we look at certain characteristics in terms of their development, and boys for that matter. We look at, on the x-ray, there's some growth parameters that tell us how much growth they have left. There's sort of a skeletal maturity index on the pelvis that correlates with how much spine growth. There's also a hand film that we're using more and more to sort of fine-tune exactly how much growth they have left and where they are in that growth spurt. And so indications are fast-growing child, 20 to 45 degrees of age.
Okay, and so I know that in our past Facebook Lives we talked about the different types of scoliosis. Is there a certain type of scoliosis that really requires bracing maybe over another type?
Well, in general, I think the adolescent, the otherwise healthy child, idiopathic, where we don't know the cause of scoliosis, is the most common. So adolescent idiopathic scoliosis is the primary patient that we brace. Certainly any other child who's doesn't have to be older than 10, can be any age, so we use bracing. We also use bracing for other sort of diagnoses, but congenital, generally we can't brace. The typical neuromuscular patients, a child with cerebral palsy, is typically not braced. We do other things with our orthotic department occupational therapy department with their wheelchair and wheelchair modifications.
Okay. And just a reminder that we're taking live questions, so if you have any live questions, post them below. Kind of moving on, what are the benefits of bracing? I know that obviously surgery is an option when it comes to scoliosis, so maybe what should parents know about what's a benefit of it?
Yeah, I'll give you my perspective and
Yeah.
then Don's. First off, I'd say that, here we're incredibly fortunate to have, Don's department and Don's leadership down here in orthotics, that when we're in the clinic, and Don and I don't work directly together, but one of his team members and I work together, that when we're in the clinic, we see patients together.
Mm-hmm.
And so we try to make decisions together about, okay, is this a good indication for a brace? What type of brace should we use? How many hours a day or at nighttime should the brace be used? So, and then once that decision's made to go with the brace, then we turn it over to Don and his team, and they make a custom-made brace, which I think we need to talk about how they do it, and the sort of the devil's in the details, I always say, because the brace has to be really good. It has to be custom-made for each child, which it is, and then it has to be fit appropriately. And so I'm going to let Don talk about that. So we're really fortunate to have it. It's a unique feature of this institution, this hospital, to be able to work in tandem as a team in doing that. So that's good.
Absolutely, and as you mentioned, I think having the team atmosphere is certainly very helpful to us down here as well. After the child is seen in the clinic and basically it's decided to go ahead and start bracing, what we do is, there are two different styles of braces typically that we are using here. One is a full-time TLSO brace, which stands for thoracolumbar sacral orthosis, and the other one is a Providence nighttime brace. Okay. Those are the two most common forms of braces that we're using. The nighttime brace is typically prescribed for curves that measure below 35 degrees and are typically in the lumbar or thoracolumbar spine, which is the lower portion of the spine. And those, what is shown, the research has shown that those are the curves that are more able to be controlled by just wearing a brace at nighttime, and that's 8 to 10 hours just while they sleep. Okay. The full-time TLSO is prescribed for anywhere from 18 to 22 hours, depending on the physician, and that's the one that we are taking down here. We're bringing them down to the orthotics department. We then use our scanner, which is here, and this is an optical laser scanner, and we take a scanned image of that child, and here's just an example of what a scanned image is. And you can see this is a patient that had their torso scanned. They have a right thoracic curvature, which shows that the waist is sort of shifted a little bit to the left in this area. And this is really how we start making the brace. From this, we take this image and we dump it into our program that allows us to modify the brace. And that's this program here. Again, you can see a right thoracic curvature here, and basically what we do is we take and modify the brace or this mold before it is actually carved. And this just sort of gives a quick illustration of how this mold is modified. What we're trying to do is push where the apex of this thoracic curve is located, and we're trying to have another points of pressure up higher under their arm as well as down in their waist to try to get that curve straighter while the brace is worn. So we do have to push on the spine, which is we're pushing on the ribs mainly, and we're also trying to derotate that spine a little bit as well. So it's taken in a 3D picture of the spine to treat all aspects of their scoliosis.
Wow, very hands-on.
It definitely is, and it's something.
Have some of these too.
Yeah, here's a couple samples of them, and we do let the kids pick their own sort of design and transfer. Wearing a brace, it's hard work for the kids to do. Our biggest aspect that we have to balance is compliance with wearing it. Right. Dr. Scotto is going to ask this child to wear their brace for 18 to 22 hours a day, and their compliance with wearing it that many hours a day is really instrumental in the overall success of our treatment plan. Right. I have to do my job and design a good brace, and then we're asking them to do their part with wearing it the 22 hours a day. Here you can see just a sort of sample of one of our brace sensors that we put in most of our braces. And this basically shows every day that they have their brace on, how many hours in the day they're wearing their brace throughout the course of this 3-month period. So this patient here was averaging 15 hours of wear a day, which was pretty good.
Right.
So that's, it's an idea. We put these buttons in to give feedback
Yeah.
to the patients to help.
Because I know that that's a big research aspect of,
Yeah.
Dr. Lori Carroll's doing a lot of it. I know that you've been
So
an author on all of that.
yeah, so I think there's a lot of things that
Yeah.
Don has sort of described that are sort of on the cutting edge. This sort of laser optic body scan is something that's relatively new. Even out in there in the community, tape measures are still used. So this is really custom and allows them to really look at the body shape and make a custom brace. And this is all done in this shop. This is
Right.
done in-house. And then the temperature sensor is stuff that we've been doing for the last 8-10 years. And now we've studied it and demonstrated that if you monitor it, the children actually wear the brace more. It's kind of like supervision,
Right.
you know?
Big
So
Brother is
Big
watching.
Brother's
Exactly.
watching, yeah. And so we can, and the nice thing is it's not there's no retribution. You just sort of say, here's your data, and the kids like to see, everybody's competitive. They want to wear the brace. And so there's all sorts of strategies that we sit down and say, okay, you're not wearing it during this time. Why is that? And maybe that's okay. And maybe you can have a break on that particular day. You got a big swim party coming up on next Saturday.
Right.
You're not going to wear it more
Right.
than 8 hours a day. That particular day, that's okay.
And that's exactly right. The kids usually know when you show them the data and they can see the little blips when they're not wearing it as much. They could usually say, "This is the reason why I was out of my brace
Right,
at that point."
right.
And they know they're being monitored
And
or watched.
And
But it's all in essence to help them with their treatment.
Right.
And
So when we do the brace, when we prescribe the brace, so they take the body scan that day, and then they fabricate the brace here. It usually takes about a month or so.
2 to 3 weeks.
Yeah,
yep.
2 to 3 weeks, depending on how things are going. And so then they have a separate appointment with Don and his team. The patient comes in and they go through the full fitting, get all the T-shirts and all the things that get done, and then we see them a month later to say, how are you doing with the brace? Are they ramping up on the hours? Because they're not going to wear it 18 hours a day for the first day. They're going to sort of ramp up. And then we sort of talk about strategy. We also make sure that the X-ray in the brace is good, meaning we get some correction in the brace. And then we sort of talk about how we're going to ramp up hours. We talk about any pressure spots. They're again in the clinic with us and sort of fine-tuning the brace if it needs
So
to
when
be.
they get a brace made for them, let's say for the first time, and they're going through their treatment, is there, as they progress and their spine gets straighter, are you guys modifying that same brace to fit them to that, or are you making a whole new one?
Yeah, typically kids are growing.
Right.
This is we're bracing them during big growth spurts and things of that nature. We are always adjusting their brace as they need adjustments done. Usually we can get about a year to a year and a half out of a brace before it needs to be remade due to growth. The other aspect that when we would remake them is if for some reason we didn't get the correction that we wanted to, then we go back to the drawing board and try to, again, optimal way to treat the patient. We want to do what's right for them.
Okay.
And remember that the brace corrects them while they're in the brace so that as they grow, the curve doesn't get any bigger. As soon as they come out of the brace, the best we can hope for is that the curve is where we started. And that, if that stays there, that's a success.
Yeah.
Because they avoid surgery and
Right.
they live their life just fine with a little scoliosis.
I think we just got a live question, actually two. First one is bracing an option or effective for someone that's a little bit older, maybe like in their 30s, who didn't get this treatment younger?
So bracing in general is for people who are growing fast and to prevent the curve from getting any bigger.
Okay.
Once you're done growing, braces are not effective to control the curve. Someone who's in their 30s, so for someone in their 30s to control the curve, it has no utility. Now, there are patients out there that have back pain with scoliosis that a brace lumbar corset for a short period of time while physical therapy is allowed to be done to sort of gain muscle strength and sort of protect them and give them some support for a short period of time is probably a reasonable option. But to control the curve, only during growth.
You got to catch it.
Yes, exactly.
Okay. Another question is, if bracing isn't an option, what are other treatments?
So if bracing isn't an option, in a child who is if a child is still growing, generally bracing isn't indicated if the curve is so big, then surgery is necessary. So in general, curves up to about 45, 50 degrees can be braced. Once you get past that, it's really hard to brace because the curve is a little big. It's hard to push up against it, number one. And number two is, even if you could brace it and hold it, you know, in that 50-degree range, 50 degrees and above, that curve wants to get bigger anyway into adulthood, and so surgery is indicated. There are other things that are out there that for smaller curves, where a brace is probably not indicated, a real small curve, let's say a 15-degree curve in the lumbar spine. So we have a study that was sponsored by the Scoliosis Research Society, funded through their research committee, and Karina is one of our therapists. She's the one who's the primary investigator. She won the award, and so we're looking at something called the Schroth method, which is one of probably a handful of scoliosis-specific exercise program, and so that's something that's also available. Pretty labor-intensive, has some promise, so we're looking at it. So if a child presents like that, they're able to be enrolled in that study. And if they're braced, the Schroth may have some benefit too for compliance and other issues too. So there's a little bit other options.
Okay. And I think, you know, Don, you and I were talking about this a little bit before we got started, but one of the questions that came through yesterday was, what changes and innovations do you think will occur with bracing in the future? If they work, will 3D printing bracing become more available as an option?
Yes, and you know, it is something that is going on right now. There's at least one company that I know of that is 3D printing braces. The downside at this point, I think the technology is out there and the materials for 3D printing aren't there to do it. You know, so we currently, the current process is you almost have to make a test brace before you have it 3D printed, and even at that point, it's very expensive at this point. Until the materials that we can 3D print can vary as far as the flexibility or stiffness of the material in certain areas of the brace, I don't think it's going to be a great avenue to go to at this, you know, at this point. But you know, 3D printing's everywhere nowadays. It's a huge topic, especially it is, especially in orthotics and prosthetics. You see it a lot of times with artificial hands and things of that nature nowadays. So it will go down that way eventually, and that's one of the beauties of this CAD/CAM system is we can actually take a mold and then send it to the 3D printer from this system itself. So the hospital does have a 3D printer here. Eventually, as the technology goes down that way, we may move sort of in that direction, but it's going to be a little while.
That's very cool.
Yeah.
Very cool. I think another question that came through, what is the percentage of adolescents that the brace is ineffective at preventing surgery?
That's a great question, and so so there aren't many studies that get published in the New England Journal of Medicine, and a multi-center study was done that looked at the effectiveness of bracing, and it was about 75% effective. So now that's all comers. That's not looking at a lot of specific variables like time in the brace. I mean, there was a little bit of investigation of that, but I think overall we like to think 80% of the time we can be successful in preventing that curve from getting to a point where surgery is necessary. But there's many factors. If a child comes in and they have a 40-degree curve and they're very young, we only have that 10 degrees to play with before they get to 50 degrees. So that's a little bit of an uphill climb. Right. So the sooner we get to them, the smaller the curves are, the more effective bracing is.
That's good.
Yeah.
Before we were talking about research, I know it's a very big here, especially spine research. So I know last week you just got back from a Scoliosis Research Society.
Yeah.
So maybe talk about what was presented.
Yeah. So the Scoliosis Research Society is a society of those who take care of scoliosis, providers of all sorts, surgeons, therapists, orthotists, etc. It was started in 1966, so it's 52 years now. And so there's an annual meeting, and several of us attended that. We attended to learn, we also attended to teach, so we had 6 podium presentations, which is out of 120, it's pretty darn good. Yeah. And so bracing was a big part of what we presented, and so Don and his team were part of this. Lori Carroll has sort of spearheaded on the medical side some really groundbreaking research. The temperature sensors, time in the brace, how to divide up the curves into thoracic and lumbar curves. So that was presented, and so that data is really interesting to say thoracic curves don't respond as well as lumbar curves. Sort of the first time that was really looked at in really challenging curves. So That was presented. There was other presentations by the staff here on other things,
Yeah.
spondylolisthesis, other things on scoliosis. So we had a strong presence there. And we also learned. We listened to other investigators throughout the country and the world. It's an international society.
And
So it's a very successful.
vitamin D was a topic of
Yeah.
discussion at there as well.
Yeah.
correct?
Yeah, and so vitamin D has been looked at by a particular group in Asia about looking at making sure your vitamin D levels are high and your bone quality is good and preventing progression of the curve over time. So take your vitamin D.
Yeah,
It's good for
a
you.
lot of good information.
A lot of good for vitamin D, yeah.
That's great. Well, I don't think we have any more live questions, so I think that kind of wraps up today.
Great.
So this was really fun. Thank you
Yeah.
both for joining us.
Thanks, sorry I was late.
No, it's okay.
Yeah.
It's live. We got to go with it. So tune in next week. We'll be back on Wednesday. Thank you.